So endocarditis, role of echo, CT, CMR, that's the topic I've been given. So kind of what we want to do is review some of the historical and imaging characteristics of infective endocarditis, demonstrate some of the findings of non-bacterial endocarditis, which we hear a lot about, but there's clearly sometimes confusion about that. Review some of the complications that we actually see here frequently, and demonstrate the role for CT and CMR for both diagnosis and management. All right, so you're all familiar with this. First of all, sound level's okay? You can hear me over there? Yes? Yes. All right. So modified Duke criteria. Is that screen kind of wavy, or is that my glass? It's a little wavy. All right. So basically, this has been around forever. This is the one that we really use. Definitive infective endocarditis is two major criteria. And the major criteria are an actual growth of bacteria, or a murmur, which we rarely say is enough. Typically, it's echo evidence, basically a vegetation or an abscess. So that's really the hallmark, and that's why in imaging there's a lot of emphasis on identifying what a reasonable pathologic lesion. So it's really what's a vegetation, an abscess, or a consequence of an abscess, which is something that was an abscess and has evolved past an abscess. So we'll talk about what that is. These are not criteria that we apply clinically. These are basically research criteria. So if you're going to do a chart review of 1,000 cases and you want a uniform definition of what endocarditis is, then we have these criteria. But they're similar to what we do clinically, but I must say we do a lot of echocardiography based on a suspicion of endocarditis, and we'll come back to really what's an appropriate use. So a few slides on the clinical stuff for the fellows. So Janeway lesions are these events in the hand typically. There's still discussion about whether they're embolic events or vasculitic events or really immunologic events, but the description is really of a flat, painless lesion on the hand. We don't see them as much as they were previously described, and that's largely attributed to the ubiquitousness of echo. So endocarditis we're finding sooner in its natural history. There aren't many people walking around for 6, 8, 12, 10 months with endocarditis, which is typically the chronic endocarditis that leads to some of these sort of cutaneous manifestations. But if you look for it, particularly after the echocardiogram has been done and you see a big vegetation, you will actually still find these lesions on our inpatients. This is a neat sort of case report that was in JACA a year or so ago, a couple of years ago. And this was the presentation, actually presented with a painful red eye, with basically pus here under the lens, the Janeway lesion in the hand, which was very large, and then ultimately the echo was done and clearly showed a vegetation. I love with all the complexity of these imaging, they put top on the image of the face, which I think most of us could have figured out. But just to show that endocarditis really is a systemic illness. It's not just an illness of a valve. Okay, so what is a vegetation? So this is the typical native leaflet infective endocarditis. So the hallmarks of the imaging here is that the term is oscillation, which really means it has a movement that's independent of the cardiac motion. So if the valve is moving perfectly like this, if the lesion is also going synchronous with the valve, that's not oscillating. Oscillating means it's got its own thing. It's going at a different frequency, a different speed, a different repeat rate. And if you look at these things, they're related. But once it's up in systole, up in the atria, it's flipping around and doing all kinds of things that the valve is not doing. So that's what oscillating means. It's independent motion. That's one of the hallmarks of an actual vegetation, particularly a bacterial vegetation. So what is histologically the lesion? So one of the features is that they tend to accumulate on the flow surface. So that's important. So the flow surface of the mitral valve is the atrial side. The flow surface for the aortic valve is the ventricular side. If you have a prosthetic material, all bets are off. But on native valves, you tend to get the base of the lesion is on the flow surface. And this is sort of the pathogenesis of how a vegetation gets created. So typically you start with some sort of disruption or damage. So whether it's a congenital lesion, an acquired lesion, it's very difficult for bacteria to seat on a completely normal valve. That's why you don't see it on a typically normal valve. So if you use a bicuspid valve, it's a valve with prolapse, it's a prosthetic valve, maybe just a degenerative valve in an older person, but it's unusual to have that tissue break that allows the contact and the growth on a completely normal valve. Not unheard of, but uncommon. So usually there's some element of either clear tissue damage or just a very abnormal hemodynamics, like the stress and strain of a bicuspid valve. Then you get local inflammation. You get some fibrin and platelet deposition, bacterial colonization. Then you start to get a small vegetation. That small vegetation gets sort of relayered with fibrin, and then it just sort of creates this cycle. So if you actually look into a lesion, it's these multiple layers of platelets, of fibrin, of bacteria, and then ultimately this keeps growing, and then you get either local tissue destruction, such as a perforation of the leaflet or an abscess, or pieces start to break off. And, that's when you get really big. So typically, in surgery, this is what these lesions look like. This is an aortic valve cut open. This is sort of, thin or thick, friable stuff. That's just a vegetation. They could look very different depending on what the bacteria is. Microscopically, this is what it looks like. It's a combination of fibrin and platelets. The pink stuff is the platelets mixed with inflammatory cells and bacterial colonies. So that's all in there. So that's called that's an active bacterial vegetation. The bugs, long list of bugs, long list of risk factors. We've seen a lot of these, not every one, but a lot of these will eventually come through the echo lab at some point or another. We've got the very common ones like Staph aureus, Staph epi. We've seen fungus, we've seen nocardia. When you start to get into post-chest being open, so a prosthetic valve, that sort of increases the list. If you have any sort of immunocompromise, post-transplant, cirrhosis, obviously HIV, you get a very big list. So we're not going to go through all this list, but there's, it's amazing. And in fact, we had some good clinical rounds recently. Yeah, Dr. Q.
Very interesting that this table, they did not include a very common that we see here quite often. If you little lady or old guy gets a knee infection or replace knee infection,
Yeah.
they don't put it as
a risk factor. Yeah.
It's not because that's really
hardware. I think that's indwelling medical device, maybe.
Yeah, I guess
it'd be up there, but that's a very good point. So one of the big epidemiologic shifts within endocarditis is older patients are becoming increasingly patients who present with endocarditis because they have more and more devices, more pacemakers, more defibrillators. Who knows what's going to happen 10 years from now when we look at all the Watchmans, ASDs, TAVRs. This is a lot of hardware sitting inside a blood vessel now. But even without that, people are living longer with diabetes, living longer on dialysis. So there's a lot of concern about indwelling catheters and prosthetic devices combined in a population who have an inherent immunocompromise. It's an example of a fungal mass. They can grow enormous. This one's 5.5 centimeters, not stretched out, so they can get really big. We'll talk a little more about prosthetic valve vegetation. So this is a bioprosthetic mitral valve. The veggies can be on the struts, on the sewing ring, or on the prosthetic leaflets. They can really be anywhere, and we've seen every version of that. So this is one that we kind of see quite often. This is a little vegetation on a native aortic valve. And you look at that and you have to sort of, well, is this a Lambles? This is a small, little friable, non-infected, benign thing that can occur usually on the nodules of Arantus. This is on the flow surface, right? We talked about on the ventricular side of the aortic valve. So it's mobile, yes. It's on the flow surface, yes. It has a bit of synchrony with the valve opening and closing, but it might be, it's consistent. You'd be concerned about endocarditis for sure. Here's another one. This is a mass in the ascending aorta. Here's the pointer. Over here, this is several months after a surgical aortic valve implant. And sure enough, this mass ended up being very concerning, viewed multiple times, getting bigger over time. Fungal culture is positive. It ended up being a fungal mass, so basically fungus at the time of either during surgery or shortly after surgery. There's another one, tricuspid valve. Again, trying to keep it pretty small, but present on the flow surface, so the atrial surface of the tricuspid valve, the RAs at the bottom, RVs at the top, oscillating, linear, meets sort of the echo criteria of a vegetation. And that was in fact I think that was a Staph aureus vegetation in an IV drug user. This is a tougher one. Clearly an abnormal mitral valve. This one, sort of the big lesion here on the anterior leaflet sort of breaks the rule of oscillation. But if you look back here on the posterior leaflet, there's some pieces that are oscillating, and it's kind of all over the place. And this is the one that's probably toughest and doesn't like to follow the rules as much, and that's native valve or fungal endocarditis. Fungus can do all kinds of stuff. It can be small, big, oscillating, wide base, small base. There aren't many rules that a fungal infection is going to follow. So the other term you hear a lot is non-infectious endocarditis. So the most common non-infectious endocarditis or sterile endocarditis, certainly non-infectious. The biggest one is pre-treated. Somebody shows up with a fever, boom, right away they get antibiotics. Then they get worse and worse and worse, and they finally come to hospital care, 3 to 4 or 5 days later. And now they've had 4 or 5 consecutive days of antibiotics, and nobody can grow an organism. So that's not really a criticism, but that's the most common reason we have culture-negative endocarditis is because of had previous antibiotics. But this is a different beast. This is really non-infectious. So if you look again here on the mitral valve, there's some little wigglers. They sort of meet that definition of they're independent, they're oscillating, they're not moving clearly with the valve. Looks like they're on both surfaces. They're on the atrial surface and the ventricular surface of the mitral valve. And this is the kind of thing. These are Lippmann Sachs endocarditis. This is what they look like when you open them up. They're very flat. They don't have long mobile elements. They can even go into the chordae, including subvalvular, not a flow surface necessarily, at least on the particular side. And typically when you get these guys, the most common association, are these non-infected sterile veggies. So they're also called non-bacterial thrombotic endocarditis. Lupus is the most common risk factor for these. So if you know somebody has lupus, I don't know, it's probably conceivable you could find the veggie and then diagnose the lupus, but more likely everybody knows they have lupus, then they get an echo, and then try to make the connection between the wiggler and the known diagnosis of lupus. That's the more common scenario. But they're not as big as you typically see, and they're usually around the closure line. So chordae, closure points as well. And they're bland, so this is what they look like. No bacteria, in contrast to the bacterial vegetation, which stains dark. So they're really very different, but on an echo, they could look pretty similar. The other one is non-bacterial thrombotic endocarditis, or another term for that is merantic endocarditis. They're more common on the aortic valve, and they look like this. They're sort of right on the cusps of the aortic valve. They're rarely longer than about 0.5 centimeter. They tend to embolize, so they're quite different than other kinds of endocarditis. They're thankfully very rare, and they're really associated with adenocarcinoma. So typically the patient has a known history of adenocarcinoma, often of the bowel, and then they get an echo, and you find these little wigglers, and you think, how unlucky is this person? You do cultures, nobody can culture anything, and then finally somebody makes the connection. Maybe this is mucinous adenocarcinoma. So merantic endocarditis. Tough diagnosis to make, but part of the differential when nobody grows anything after an echo. Yeah.
Well, those types of non-infectious, will they ever cause significant valvular dysfunction?
Yeah, unlikely. They're not destructive. That's a good point. They don't. Well, part of it they're size restricted, so you can get AI. They interfere with coaptation zone, but they're not locally destructive. They're not gonna chew through the valve, cause perforations. Clearly, there's never an abscess or anything like that with them. So that's a good point. And I think often people die with them, not because of them. All right. So common complications of endocarditis. This is an obvious one here. Some thickening here. You see this destruction. I've actually got movies, I think, that show this a little better. This is one of my patients. So a leaflet perforation. We've had many cases of that. Often it starts as a windsock. So basically it's a local inflammation. It gets bigger and bigger and bigger. And it actually looks like an outpouching through the leaflet, often the mid-belly or the mid-portion of the anteromitral leaflet. It blows around, and then ultimately it'll perforate through the end. It'll pop a hole through the end, and you get these tunnels of flow. So the perforation is fairly common. It's actually generally a fairly easy surgical fix if that's all it is, if there isn't an associated abscess, because they can actually just cut out and patch if it's really contained in just this kind of thing. But perforation is very popular, and that's one of the things that endocarditis can do. It can chew through any tissue plane. So when you've got these tissue planes and these natural planes of dissection and things like to come apart in a certain way, various bugs will attack that differently, and they can be incredibly destructive, and they don't necessarily have to follow any of the normal tissue planes that the surgeon will be identifying. All right, so this is another one. You see a little wiggler over here, sort of at the base of the posterior leaflet. Look closely there. A little bit of AI on color. There's a funky bit of mitral regurgitation. And the key thing to recognize, anytime you see regurgitation that's not coming to the coaptation zone, you got to be suspicious of endocarditis and a perforation. So oftentimes, if you're, that's part of the mantra we talk about is if you see MR, you should be asking, why is there MR? And if you just say there's MR and move on, that's not enough. This is clearly a case where the MR is originating from a place that's not the coaptation zone. And you can see that it's starting way at the base of the posterior leaflet, way back here. The coaptation zone is here, where the leaflets come together. The MR is coming from over here, and there's the big perforation through the posterior leaflet. So that's very important to recognize on imaging. And this is about as bad as it gets. This is the same patient, and they're descending aorta. So they have a dissection. They have was an abscess. It's now a cavity. They have mobile wigglers. So they have a penetrating ulcer, a vegetation, a dissection flap. So when you have basically this infection that travels deep somewhere else, brain, descending aorta, still associated with a blood vessel, you call it mycotic. All right. So here's a little bit on the aortic root, and this we see a fair bit. So aortic root abscess. This is sort of what it looks like when it's early. It can be kind of homogeneous, it can be thick. This is obvious on a native valve. This is clearly, this thickening you don't see. The challenge if you see this after a surgical valve. If you have a bioprosthetic valve, your image quality is good, and you see some peri-valve thickening, the challenge there can be how fresh is the surgery, because you get thickening and bleeding, and all these things can be quite normal in the first few days or weeks after surgery. But once you get up to about 6 weeks and beyond, you shouldn't have that peri-aortic thickening. So on a native valve, it's easy. That's always abnormal. On a surgical valve, the timing and the extent become an issue. So that's basically a hallmark of an abscess. It's nice. This is a different one. This is actually an aortic root and LV. So down here, this is an extent of the problem, and up here, and all the way down into the anteromitral leaflet. So this is an example of this. This infection can really go anywhere. It doesn't have to be contained at all. This is an X-plane. We're in a phone call somewhere, in a conversation.
They're not muted on their end.
Who's on the other end? I didn't know somebody was there. I don't even know where they are. Hello over there. Turn your phone off. All right, so this is a good use of X-plane. So you see an X-plane through the aortic valve and short axis on the left, the long axis view on the right. This one, fortunately, is not looped, but I guess it doesn't really have to. Here the abscess looks a bit different. It's a bit variegated, not as homogeneous. There's sort of different populations. You can imagine if you cut into that, you'll have some bits that are sort of contained and others that aren't. But that's pretty classic for an abscess as well. This is getting a little different now. This is a pseudoaneurysm. So the distinction between an abscess and a pseudoaneurysm is simply that as soon as it's no longer contained, it's no longer an abscess. So the definition of an abscess is it's walled off, with no flow. So therefore it's not pulsatile, it's not going to have any color Doppler, imaging. And as soon as it ruptures on one end, pus is gone. The patient will have a fever for a little while because the pus hits the bloodstream. But basically now you've got open at one end, so it's going to get pulsatile. So the natural history is abscess, then typically pseudoaneurysm, meaning open at one end. And that's what you see here. So that pulsatility, this is sort of the natural history. So you can put color on there. You'll see flow in. You can put pulse wave on it. You can demonstrate to and throw flow. There's the color. It's pulsating. open at one end. And this area that opens is the intervalvular fibrosa. It's that common tissue between the aortic and the mitral valve. Very common to be an area of infection. There's some Doppler. And then this is the natural history. So it opens at the LV side, and it can actually open at the aorta side. So now that's a fistula. So when it's open on the aorta and the ventricle, the flow can go all the way around. So it's open on both ends, that's a fistula. The definition of a fistula is a connection between two chambers that shouldn't be connected. So abscesses contain, pseudoaneurysms open at one end, fistulas open at both ends. And as soon as it pops at the other end, you lose that pulsatility because it's not connected anymore. So the pulsatile means it's got to receive pressure and expand and contract. But now it's just a conduit, so it's less pulsatile, higher flow. It doesn't really matter, they're all surgical indications, but it matters in terms of the nomenclature. If you're going to read the reports, write the reports, use the right words. All right, so why does all that happen? So here's the heart valve anatomy. Aortic center, mitral here. This line sort of represents the fibrous ring around the mitral valve. This area here is the continuity between the aortic valve and the mitral valve. This is the anterior mitral leaflet. So this is the aortic mitral curtain is one term. The other term is the intervalvular fibrosa. They're referring to the same thing. It's the tissue that runs right between them. For the fellows, what's the arrow on? What is that thing called? Anyone? Fibrous trigone. Yeah, left or right? Left. Yeah, wasn't a trick. Well done. Left fibrous trigone. Your leading question. Cassie, what's that? The right fibrous trigone. These matter because the strongest elements of the cardiac skeleton sort of holds the structure in place. The heart works because you've got a skeleton that keeps some parts from moving, and all the other stuff moves off of it, right? The ventricles move, the valves move, but you have to have something that's kind of anchored, because if everything is moving, nothing will be coordinated and synchronous. So there's a part that doesn't move, and that's the cardiac skeleton. The fibrous trigones are the strongest part of that skeleton, so they're kind of like the gristle in the steak. When you bite a steak and you hit the gristle, nobody can chew that. You can chew that all day. That's what a fibrous trigone is like. And what runs between them is the aortic mitral curtain. So that's another fibrous bit. This is the part that's very important because the surgeons, when they have to go in and fix this stuff, as soon as you're messing with the cardiac skeleton, the continuity between the aortic mitral valve amps up the complexity of the surgery and amps up the challenge of getting rid of all the infected material. So recurrent endocarditis, if you can't get rid of all the infected material, then you can't really ensure that you're not going to get reinfected, or the infection is really dealt with. Another slide to demonstrate that. Oh, so what else is down here? Little trivia. So the right fibrous trigone is here. What else is here? Josh, I didn't hear. Yeah, what tissue is here? Well, yeah. So the His bundles run right through here. The other element thing is down here, kind of right in here, is the membranous septum. Right, if you're looking up from the ventricle. So this is all called the central fibrous body. It's got the right fibrous trigone. The His bundles go through there, and the membranous septum. The top uppermost portion between the left and right ventricle. So imagine an infection that hits this and disrupts everything. Conduction delay, VSD, intervalvular fibrosa. We often think of atrial events and ventricular events, mitral events and aortic events, but really this is a common tissue that gets hit. That sort of explains all the things you need to look for. All right, so this is 3D echo. Just want to demonstrate that important commonality between these tissues. So aortic valve, anterior leaflet, posterior leaflet, aortic valve here. And this here is the intervalvular fibrosa. And I think a little highlight here, yeah. This little curve, watch the bulge that occurs right here. So that's the bulge. When the aortic valve is open and the systolic pressure wave is going through, it actually pushes on the aortic mitral curtain, hits the anterior mitral leaflet, and helps close the mitral valve. So that continuity is very important. The valves don't work by themselves, they work in synchrony, and that's a view that shows that. And it also, this one play? Yeah. And that's just looking from the ventricle up. So there is the aortic mitral curtain from the ventricular side. So I think it's important just to understand that anatomy. When you're talking endocarditis, that's a natural place to stop and think about this stuff. But this has implications for surgical repair, for mitral valve replacement, for transcatheter mitral valve work, for transcatheter aortic valve replacement, all of that all of those activities require some knowledge of this anatomy. And this is sort of the crux of the heart we talk about. We do a lot of 4-chamber imaging. CT, MR, echo, doesn't matter. But the crux means that you've demonstrated this spot right here. And when next time you're looking at a 4-chamber view, ask yourself, what's not moving? The part that doesn't move is the center of the crux. That's the fibrous skeleton. Everything moves off of that. And this is sort of just a schematic that shows the fibrous elements. So this is looking from the back of the heart. So this is the mitral annulus is here, over here. And then the aortic annulus is not a true circle. It's more of a crown that holds up the aortic leaflets. So you've got this crown for the aortic valve. You've got an almost complete ring for the mitral annulus. It's not as complete down here. That's why this gets calcified and why we have MAC back here. And then you've got left trigone and right trigone. And this is all the continuity. So these rings are the parts that don't move, and everything else moves off them. But endocarditis can get in there and just wreak havoc with all of that. All right, so that was sort of the preamble to the potential complications that you can get. This just shows a vegetation here just under the aortic valve, and there's the perforation through there into the right heart. So again, particularly through that membranous septum, you can get perforations. This is a fistula from the aorta into the RA. Pacemaker problems. This is a massive vegetation on the right-sided pacemaker. Very mobile, sort of meets all those classic things. It's oscillating, it's mobile, it's attached to hardware. This one's fairly easy, but we're often asked, is this thrombus or is this vegetation? And it's still very hard to know. Thrombus can sometimes oscillate. Vegetation can be huge. Thrombus can be huge. MRI, perhaps not on a prosthetic valve or on a prosthetic material, but MRI with tissue characterization would be one way you could approach this if it were on a native leaf. I don't think you could do that on a wire. But this was simply the wire replaced, and that was clearly defined as endocarditis in this case. This is the pulmonic valve. Very long linear strand coming up from the pulmonic valve across the valve, associated with PI, so a lot of pulmonic insufficiency, and that ended up being a large vegetation and IV drug user. And the important thing to remember, on the right side of the heart, the embolic events go to the lungs. So you can get empyema, you can just get pleural effusion, you can get septic emboli in the lungs. We do a lot of CT, so in terms of why CT for endocarditis, if you're worried about right-sided endocarditis, CT makes a lot of sense. You're looking at the lungs as well. All right, so we have these sort of algorithms for effective use of echo. So when you suspect endocarditis, if they're low risk, and you do a transthoracic, there's almost no threshold to do a transthoracic, but people do a transthoracic. If it's positive, you treat, and you're done. If there's high-risk features, meaning things you think you might need to go to surgery for, which are lesions greater than a centimeter, overt clinical heart failure, prosthetic valves, or clear abscess. Really, those are the reasons if you suspect any of those on a transthoracic with a positive study for endocarditis, that's when you'll go on and consider a TE. Not necessarily a TE for anybody who has a positive culture and a positive transthoracic. So positive transthoracic does not equal TE. There's a few cases where it helps. Dr. Q, any comments on this sort of algorithm? I mean,
yeah, I actually reviewed a paper a few months ago, they did something cool. I thought they had configuration 100% configuration. And what they were trying to do is modify a little bit what is a negative transfer.
yeah.
And of course, pristine quality, clean, negative, no. That's it. Positive, definite, great. Question is that there's always a lot of in-betweens. So the in-betweens, what they found is that basically at the end, the message from the study was, if you see any focal pathology in the body, even if it's calcium or whatever, that should be addressed. If the valve is leaking, it should be addressed. And if you have, of course, any prosthetic material of any kind, that was a red. So all of those then suggest basically what to do. And then they apply the algorithm prospectively after they did some of that cleaning, and it was very successful. And I thought it was a nice paper because it possibly helped in establishing when we can say no. This is it. We're sure. Don't bump us anymore. Go out and do something else.
Yeah. I think it's a
So
challenge.
it's kind of the same here. So they were just tweaking to see exactly what is a negative.
I think I predict what's going to happen in the next 3 years when we change payment models. When the imaging falls into a DRG for a hospitalization, there's going to be a lot more focus on algorithms for when not to do stuff. So now there's really no financial incentive or hospital incentive not to do echoes on everybody. We get echoes for fever. Don't have to have a murmur. Simply fever. Fever equals echo. Those days are not going to last once there's sort of a feedback loop to the attending saying, okay, you've ordered a $600 study, it's coming out of your payment. All of a sudden, those are going to fall away. Now, sort of focus on appropriate algorithms are going to become much more a bigger deal for all of us.
How is it in Canada?
It's a different mindset. There's more of a gatekeeper mentality, and there's a wait list.
But you're in the hospital,
Oh yeah, not intentional, but
just by virtue of
they don't advertise we have a wait list, but it's the best thing for appropriate. You don't need any appropriate criteria if there's a wait list. If it takes you 5 days to get an echo, you don't order it because it's your own patient. So that's it. That's how they deal with it. You're an inpatient. You want an echo. It's 5 days to get your echo, or you can discharge on day 3 and do it as an outpatient. So that's how it works. Yeah, wait lists are a great cure for inappropriate use. So this just sort of takes you through, you suspect endocarditis, they've had a transthoracic, which is kind of our model. Everybody gets the transthoracic. The bigger issue is when is it appropriate to proceed with a TE? So if it's a non-diagnostic transthoracic, sure. If you really have a high clinical suspicion, we do that. If there's clearly complications present, and I mentioned what those are. If there's a hardware like a lead, yes. Staph aureus is an agent. Super destructive, and there's no known source, so people just shouldn't have Staph aureus in their blood. So that's a reasonable indication for TE. Prosthetic valve, same thing, and it sort of moves down the list. But simply fever with a low initial risk and a borderline transthoracic, we probably do more of those than we should. Yeah. Well, I mean, true Staph aureus bacteremia. So you believe it, whether you need 2 or 3 out of the 4 to believe it, I'm not sure. But if you believe bacteremia and you have no other source and you have a shaky transthoracic, I think that's a reasonable indication to do a T, because you don't want to miss Staph aureus. And some of these things you get a lot of people know. Okay, if it's not there, redo an echo in a week. Most things nothing bad's going to happen, except for Staph aureus. Staph aureus will chew through a valve in a week. All right, so this is just sort of a snippet out of the appropriate use guidelines. So initial evaluation of suspected endocarditis with positive blood cultures, native or prosthetic, that's deemed appropriate. So the key there is positive blood cultures, not just fever. A reevaluation of any of the things, so a very virulent organism like staph, hemodynamic lesion, aortic involvement, meaning the aorta, not just the aortic valve. Persistent bacteremia, worsening clinical status, very appropriate. And the bottom one is, native or prosthetic valve, transient fever without bacteremia. Those are the ones where that's the low-hanging fruit we could probably get rid of. All right. So the high-risk conditions to get endocarditis, any prosthetic material, we've talked about that. Anybody who's already had endocarditis is clearly at risk to get it again. And then really unrepaired congenital defects or devices. So this is the big category. So, there's no data for this, but people say 6 months. So 6 months, your first 6 months of your TAVR, your MitraClip, your ASD, your Watchman, there's a thought that that's exposed hardware. It's not endothelialized. Increases your risk for endocarditis. I don't know how much, but that's the timeline that people use. Obviously, anybody who's had a heart transplant and is chronically immunocompromised. So prosthetic valves, we've talked a little bit about. This is a mechanical prosthetic valve in the mitral position. So mechanical valves, you don't typically get a vegetation on the mechanical leaflets because they can't adhere, but you get it on the sewing ring, and that's what you see on this case. This is sort of an encompassing all around the cell ring vegetation. This is one in a bioprosthetic valve. You see something unusual in the LVOT. With color, you see flow coming from two directions. In this particular case, was done here, had contrast for the LV. Sonographer said, hey, this is interesting. Since I'm given the contrast anyway, let me go ahead and look at the LVOT. And in fact, the contrast revealed a shadow and actually delineated the vegetation nicer than you can see without contrast. So not a published indication for contrast, but you know, if you're given contrast anyway and you already noticed something interesting, why not have a look under contrast? So this is a mechanical valve in the mitral position. The defect is really up here. This is a massive paravalvular defect. This is somebody who'd had mitral valve replaced because of endocarditis, and this is recurrent endocarditis. This patient, unfortunately, it was too far gone. He had already had his entire cardiac crux rebuilt by a surgeon and didn't have an option for another one. So he didn't make it through this. This is the same image I showed you before, bioprosthetic valve showing a lot of vegetation actually on the leaflets. This is a very rare case, 6 weeks of antibiotics. I forget, there's a surgical reason not to go to surgery. Classically, the teaching is that much vegetation, prosthetic valve, go to surgery. But if it's a second or third valve and there's a reluctance to do that, you try antibiotics. In this case, became culture negative after 6 weeks of antibiotics. But the valve wasn't completely normal. There's a couple of little guys back here. But on 3D, there's 3 new paravalvular defects. So the vegetation left its mark. Paravalvular defects, and in addition, the valve didn't quite open normal anymore. So the diastolic area was reduced after post-infection, and the paravalvular defects were all new. So this is the only valve I've ever seen that actually became culture negative with prosthetic material after only 6 weeks of therapy, but not without its scars. This was a fairly recent one, actually. This is a year ago. Here, surgical valve, and actually presented, I think Dr. Q, you were involved in this one. Surgical valve presented with an abnormal systolic gradient, so didn't present with any embolic event. Came in with peak velocity of 4 meters across the surgical valve that was new. And then TE was done with a high suspicion. I forget what the suspicion was, but it was not, nobody was thinking endocarditis on the transthoracic. For some reason, you recommended a TE, I forget what it was. It was clearly diagnostic. And then this massive nocardia vegetation post-op. It was huge. It was like 3.5 to 4 centimeters long, just flicking up into the ascending aorta. Massive vegetation. All right, so I think we've sort of gone through this. We'll skip that. So let's talk the other modalities just quickly. So in terms of MRI, the times we use MRI is typically to see peri-aortic events or periprosthetic events. So if you're worried about fistulas, perhaps traveling up into the ascending aorta, and if you're concerned about quantitation, you can do this stuff. Honestly, we do a lot more CT than we do MRI for endocarditis. It has the better temporal resolution. Nick, any comments about a specific role for CMR for endocarditis? Yeah, we've done a few times, but I would suggest we probably also did a CT. That's typically how we roll. But that's where it's useful. It's really the peri-aortic events and the complexity of the extent of the disease. This one has a pseudoaneurysm cavity, in a very large pseudoaneurysm again, in between the aorta and the atria. But CT we do much more frequently for these. CT can define prosthetic valve dehiscence, the extended dehiscence, whether it's acute endocarditis or chronic. Sometimes they do survive the chronic event, or even the event isn't even recognized. Nobody realizes they had endocarditis, it clears, and now they've got a paravalvular defect that they need plugged. So, typically it's either a peri-mitral event, a peri-aortic event, and it's usually not to visualize the vegetation, it's to visualize the extent of destruction. That's usually where CT plays a role. This was sort of one of the early 4D CTs where you see a mechanical mitral valve. You can actually see a pacer lead. This video, I think, plays. This is some sort of an early software several years ago, but now 4D CT we're hearing a lot more about in one of the areas, and I'm impressed even when we've done some 3D printing off of CT, and the spatial resolution was so good it was even identifying the little pinholes, paravalvular defects around a prosthetic valve. So I think we're going to see more and more CT imaging. I'm not convinced yet that it can identify vegetation very well, but clearly the destruction it's very good at. And this is just sort of a long axis view of an LV with a mechanical valve shown there.
But one of the things I've been impressed in the case of late is even with TE, we don't always get kind of all about from an absence, for example.
Yeah. Yeah.
Within the chest. Then the CT comes in, you see that sucker, you're just going everywhere, you're compressing over the vessels, I mean, all kinds of things, even with TE.
Absolutely, particularly up the AC, the extent of the AC aorta. There's
higher,
like corkscrew all the way up.
Just having that particular issue.
Yeah.
So if you're running surgery, I think the CT clear is very helpful.
Certainly at our center, I would say every surgeon gets a CT if they're considering surgery. And I think a lot of centers will do that as well.
Makes sense.
Okay, final slide. So basically just the summary. So endocarditis is inflammation of the endocardium. That's what it means. It doesn't necessarily have to be on a valve. Just any endocardial structure that's infected. They tend to be valves, but it doesn't have to be a valve. So septum, chordae, intercardiac devices can all be infected. The lesion you're talking about is a vegetation. It's platelets, it's fibrin, it's organisms, and it's inflammatory cells all put together. Echo is the mainstay. I think we're going to see an evolution of algorithms once the payment model changes. And CT, I think, has a very important role. So I'll stop there. Any questions? So think about the intervalvular fibrosis, the relationship between the aortic valve and the mitral valve. Endocarditis is the entity that best makes you think about that because it will impact all those things at the same time, and not many other lesions will do that. Yeah.
Would it, I don't know if it works, I'm just thinking would it have to have one of those printed heart muscles in that sometimes, or we have some of those cases
Yeah.
that happens.
Yeah, we have a bunch we've already used.
There's ones I make a story, but you know.
Yeah,
Maybe.
bring some up.
I mean, sometimes we have some of these things that we cannot figure out.
Yeah, where does it go?
Where does it go? Yeah. That with the heart.
Yeah.
I mean, what a better heart to grab than one that's real.
Yeah, we have. So we have a gentleman next week. We're doing a case. He has a mechanical. He has a bioprosthetic aortic valve, a bioprosthetic mitral valve, both due to endocarditis, and now he has a hole in his lower septum. We're about to plug it, but when we're done with his model, we'll run this case, we're going to bring his model up and put it in the lab. Yeah, good example. All right, thank you, everybody.